Hello guys, today let's learn about a very important topic, that is the IHCP, that stands for intrahepatic cholestasis of pregnancy. This is a very important differential diagnosis in jaundice in pregnancy. So today I shall be primarily focusing on the RCOG Green Top Guidelines that was issued in the year 2022, and we still follow it. And this was published in August 2022, and this is the direct PDF of the RCOG guideline, which we practically also follow, and it is very important for all of us to know. So out of the 20 pages guideline, what I want you to remember is the important tables and the information within it, which I shall be discussing. First thing is the terminology for pregnant women with itching. So it is said that gestational pruritus is when the itching is present but the bile acid concentration is less than 19. So as we all know that it is mainly a problem in the bile acid metabolism in IHCP, which causes pruritus, usually without any visible rash. And it usually begins from the palms and soles, and then it can even go through the trunk, limbs, and become generalized. It can be mild to severe, and it worsens during night time. So when there is when we order the bile acid levels and it comes out to be less than 19, then we call it as gestational pruritus. Mild ICP is when there is itching, raised peak bile acid concentration from 19 to 39. It's only then when you start calling it as IHCP or ICP, and it is categorized mild when it is 19 to 39, moderate is when it is 40 to 99, and severe is when it is more than equal to 100. This is very important to understand, because our management will depend on this bile acid level. Next, they have told that the diagnosis of this should be considered in a pregnant woman who have itching in skin with normal appearance. That means there are no rashes, with peak of bile acid 19 or more, as we already told. And you should do a history, take proper history and examination, and always rule out other liver disorders or other causes of itching. Offer repeat liver function tests and bile acid in women with normal blood vessels whose itching persists. So you can repeat in them. And if resolution of itching is associated with normalization of bile acids and liver function tests, the diagnosis of ICP is unlikely to be correct. Okay, this is important point to be remembered. Why it is not going to be IHCP if it is it's showing resolution, I will let you know. So what is the role of other investigation in care of women with suspected IHCP? They have told. So imaging, investigation could be considered on an individual basis. So only if there are atypical symptoms, any comorbidities, comorbidities may be in terms of preeclampsia or GDM. So in these conditions you can offer other investigations also. So when should you seek a hepatology advice? It is when it's very early or atypical presentation of what appears to be IHCP. Postnatally, when will the IHCP resolve? So remember that this is a very important update, that postnatal period of at least 4 weeks after the birth with resolution of itching and liver function is seen, with tests returning to normal, including the bile acid. So this is important. So when are you going to repeat her bile acid? So suppose you have delivered a case of IHCP, now next you should repeat her bile acid level minimum after 4 weeks. Usually around 4 to 6 weeks is what we practically say, because it takes at least 4 weeks to come back to normal. And that's precisely why I said in the earlier recommendation that if within the pregnancy, antenatally only, if her itching is getting resolved with the bile acid coming to normal within a span of a few days or some duration, it is unlikely going to be IHCP. Then what's the maternal morbidity? See, look, per se maternal morbidity may be less It's more of a concern for us as obstetricians in the fetal side rather than the maternal side. But yes, severe itching can be very distressing for the female. She can have sleep disturbances. Also, it has been seen that they have a higher chance of developing preeclampsia or gestational diabetes. So they should have blood pressure and urine monitoring and test for GDM according to the national guidelines. So this is very important point to remember. So suppose you're dealing with a case of IHCP, also order the test to rule out gestational diabetes mellitus. So in India we follow the DIPSI guideline, according to which we are going to do this 2 hour 75 gram OGTT. So you have to offer her this test also. Obviously you should do her blood pressure and urine albumin to rule out any preeclampsia also. Next important recommendation, and this is a very important point, is the risk of stillbirth. Now, why are we concerned about IHCP? Is that it causes sudden fetal death, and it is because, to put it in simple terms, is that the bile acid is cardiotoxic to the fetus. So it can lead to sudden intrauterine fetal death, resulting in stillbirth. So they have said that in women with bile acid 19 to 39 with no other risk factors, the stillbirth is same as any other normal pregnancy. Whereas when it comes to moderate, that is 40 to 99, it is similar until 38 to 39 weeks. So this is the reason why in moderate kind of IHCP, we would like to terminate the pregnancy at 38 to 39 weeks. In women with peak bile acid concentration of more than 100, the risk is higher than the background risk. And of course, if she has any comorbidities, you have to plan the delivery according to that. So whether it is GTM or preeclampsia with severe features, you have to time it according to that. So this is an important table where they have shown that what is the prevalence of stillbirth, and that is how they have arrived to this conclusion that when you are supposed to deliver. I'll come to it because there is one more chart also regarding the same thing, so we'll learn there. Yes, they have told that IHCP or ICP patients have higher chance of having meconium stained amniotic fluid during labor and birth, and that's important because if you are planning, if you are inducing, so you can go for an early ARM and look for any signs of meconium stained liquor or fetal distress, and their baby is more likely to receive neonatal care. How often should you monitor? So this within a consultant-led maternity unit. So usually whenever we diagnose IHCP, we generally admit them in maternal monitoring. How will you do? So you have to repeat the liver function test and bile acid after 1 week and determine the frequency on individual basis. This is important because suppose at one period of gestation when you have diagnosed her, she might be a case of mild IHCP, but later again when you repeat it at 1 week later, she might have increased levels of bile acid, which could have made her a case of moderate IHCP. So in this case, the termination, the time of or the weeks of gestation where I am going to terminate her pregnancy, decision changes. So it's important that you repeat her bile acids every weekly. How do you do the monitoring? Of course, fetal ultrasound and cardiotocography do not predict or prevent stillbirth, and this is very important, has to be categorically advised to the patient and made and you have to explain it to her that even though we are doing ultrasound, we are doing CTG, but it is not possible to predict the stillbirth or prevent the stillbirth in a case of ICP. So the best way where you can do something for the patient is to advise her regarding the DFMC or daily fetal monitoring count. That's the best thing that she can do. About DFMC, I've already made a video, so do check out about the ways where you can do the DFMC. So in treatment, we should very importantly advise the patient or tell the patient that there are no treatments that improve the pregnancy outcome. So whatever treatment I'm giving, it will not prevent the risk of stillbirth, okay? But yes, it may improve her symptoms of itching, although it is of limited benefit. So what all we consider? We consider giving antihistaminics like chlorpheniramine and particularly at night, although the effectiveness is uncertain. They have also written about the role of ursodeoxycholic acid, which we routinely recommend, that is a UDCA. They have told do not routinely offer UDCA for the purpose of reducing adverse perinatal outcome. So this is important. When we are prescribing UDCA, it's basically to reduce the symptoms of itching of the female, although it may not be 100% effective, but always tell the patient that it will not reduce the risk of perinatal outcome or the risk of stillbirth. You can also give topical emollients with aqueous cream, okay? So we usually give the calamine lotion for symptomatic relief. And even the role of vitamin K also they have asked. So in this they have told that if there appears to be reduced absorption of dietary fat, then only you should give. That means there's any presence of steatorrhea or any abnormal prothrombin time, then only you should give vitamin K. So it's not that any case of jaundice you're going to give a vitamin K injection. No need. It's only when you are suspecting any abnormal coagulation profile, then only you should offer. Now this is the most important part of the guideline that I want all of you to pay attention. That is, when do you terminate a pregnancy in case of IHCP? So planned birth by 40 weeks of gestation or ongoing antenatal care in case of mild IHCP. So basically mild IHCP 19 to 39, you are going to terminate it by 40 weeks, okay? Because this risk of stillbirth is similar to the background risk. Next, if it's a case of a moderate IHCP, that means 40 to 99, then you should consider terminating at 38 to 39. So moderate is 38 to 39. If it is severe, that is more than 100 is the bile acid, then 35 to 36. This is important, and these are all strength A qualities, evidence quality 1+. So this is important, and this is on the basis of the stillbirth risk that they have calculated. Obviously, mode of birth doesn't change for IHCP. It is only if there is an obstetric reason you are going to go for cesarean section, or else vaginal delivery can very well be offered. So during labor you can do continuous fetal monitoring, okay, and if there is risk factors, as I told, you have to monitor even that. Now finally, the contraception choice is important. That remember, you can advise the female that per se the IHCP does not pose a major problem to her contraception choice or any hormone contraception. But they have told that for women with IHCP and previous cholestasis secondary to combined hormonal contraception, then you should advise them to use only progesterone method. That means if she had any drug induced IHCP, like for example she was using hormonal contraceptive because of which she got the IHCP, in this case you will advise her progesterone only contraception, or else you can very well offer HRT. To advise the women with a history of IHCP that they have an increased chance of recurrence in subsequent pregnancy, and you should offer a baseline liver function test and bile acid concentration with the booking investigation. So this is all about the green top guidelines given by the RCOG, okay? And in a nutshell, I have covered all the important points about IHCP, which is very, very important. So if you have any doubt, then feel free to write in the comment section. I'll be glad to clarify. And if you want any other topic or any other guideline to be discussed, also you can mention in the comment section. That's it for now. Bye bye.